Hi, I'm Douglas Brown. I'm from Mayo Clinic in Rochester, Minnesota, and we're going to be talking about ultrasound in the postpartum and post-miscarriage patient. Hey, we're going to be talking about pelvic ultrasound in the postpartum and post-miscarriage patient today. The main things we're going to talk about are diagnosis of retained products of conception, both in the first trimester patient and the postpartum patient. We'll talk about the imaging criteria that you can use and the limitations of those criteria. And then we'll look at a few other postpartum issues, particularly the post-cesarean section patient and some unique imaging findings related to those patients, and then a few other miscellaneous topics at the end. Patients who present with abnormal bleeding in the postpartum or post-miscarriage time frame, we generally are most concerned about retained products of conception. We do a lot of ultrasounds for this reason, and you think it would be very obvious what we could use, but actually when you look at the literature, it's difficult to find reliable predictors of retained products of conception based on ultrasound features. Variable features have been assessed, including thickness of the endometrium, area, the appearance or morphology, and Doppler findings. The criteria seem somewhat vague in many of the studies. And it's also worthwhile to note that the different studies have used different endpoints. Some have used pathology, and you may think that's great because that does give you definitely whether there's retained products of conception, or at least more likely to. However, others have used clinical outcome, and it may actually be that clinical outcome is more important because what we often want to know is whether that patient needs an intervention, whether they need surgery. And even if there's a small amount of retained products of conception that would be evident on pathology, if that patient's going to pass them and do well with conservative management, that's probably the more important thing. So we're going to consider the post-miscarriage, that is in the first trimester, and the postpartum scenarios together. There's less published on the postpartum patient alone. Most of the postpartum studies limped the post-miscarriage patient, that is the first trimester, together. There are some studies that concluded just the first trimester, but we're going to lump them together. And when it's important, I'll specify if criteria apply more to one or the other. So what about retained products of conception in the first trimester? Well, a case like this, where you have a gestational sac in the uterus, those are easy to diagnose. We know there's still retained products of conception. So otherwise, what we're looking at is what's usually referred to as the endometrium. I put that in quotation marks because it's often not just the endometrium that we're looking at anymore. It may be retained products or it may be blood products, but it's still often referred to in the ultrasound articles as the endometrium. So we can look for a mass, we can look at thickness, and we can look at Doppler findings related to the endometrium. An endometrial mass, as in this case, transabdominal scan, sagittal view, we see a focal hyperechoic mass. Different patient transvaginal scanning, focal hyperechoic mass in the endometrium. These are most likely due to retained products of conception. Could still be clot, occasionally can look this way, and this finding actually seems more predictive in the first trimester than in the postpartum patient to identify retained products of conception. So this is probably the most useful finding for identifying retained products, but still has its limitations. For this hyperechoic mass, discrepant results have been reported. Several studies in the postpartum patients report it as a common normal finding, particularly in the first 1 to 2 weeks postpartum. Other studies have found it to be a better predictor. Sonohysterogram could be used. It makes sense. If you did a sonohysterogram and you see a free-floating mass in the cavity, most of those would probably do well with conservative management based on one study. Whereas if you see attachment to the wall, those are more likely due to retained products. Certainly seems reasonable. There's not much in the literature about it, and it really hasn't caught on as the way to evaluate for retained products of conception, even though it could be helpful in selected cases. So question, what endometrial thickness best discriminates the presence of retained products of conception? Is it 2, 5, 10, 15 millimeters, or we don't know? Well, we actually don't know what number to use to discriminate patients with and without retained products based solely on endometrial thickness. So now we're talking about the patient who does not have an endometrial mass, but you're just basing the assessment on endometrial thickness. Here's a patient with a retroflexed uterus, very thin endometrium, 3 millimeters. another patient with 13 millimeters. Obviously, I think we're going to be more concerned about this patient with a 13 millimeter endometrium rather than the 3 millimeter endometrium. But what number can you really depend on? Cutoff values from 5 to 20 have been suggested, but actually if you look closely, there's a lot of overlap in most of the studies, and many studies that have looked at management of these patients have picked an arbitrary number for endometrial thickness. They have not systematically evaluated which endometrial thickness is most useful. So when you compare it with pathology, that is endometrial thickness with pathology, there's really no reliable cutoff. Again, different numbers have been looked at. In this one study from 2007, the best number was actually 8 millimeters with a sensitivity of 87% and a specificity low of 21%. Morphology is probably important in these patients, but it wasn't evaluated in this study. If you base it solely on pathologic correlation, you can virtually never exclude retained products of conception. Retained products have been reported on pathology even with a thin endometrium of less than 2 millimeters. Another study that I like to reference and depend on is an older study from 1993. In that study, they found that if the endometrial thickness is less than 10 millimeters, most of the patients do well without dilatation and curettage, based on clinical outcome. And again, I think that might even be more important than using pathology as the gold standard. So this study found 10 millimeters, another one 8 millimeters, but really the best cutoff for deciding expectant management in these patients is still not currently known. So what about Doppler ultrasound? Could that help? It certainly seems reasonable. If you see flow in a mass or in a thick endometrium, it is more likely to be retained products of conception. Here's a patient with focal mass, color Doppler imaging shows flow, and this did have retained products. However, here's another patient, thickened heterogeneous endometrium, no flow detected, yet there was still retained products of conception at pathology. So presence of flow certainly favors retained products, but no detectable flow, while favoring clot, does not exclude the presence of retained products of conception. There's another study that looked for retained products using Doppler findings. 163 patients, second and third trimester delivery. Color Doppler was performed in 29 of the patients. 16 of them had retained products, 12 of which had endometrial flow by Doppler imaging and 4 did not. 13 of the patients did not have retained products. 7 still had endometrial flow and 6 did not. So there certainly was a trend toward flow being equated with retained products, but it was not statistically significant in this study. Another study using PATH, and it was a mix of postpartum and post-miscarriage patients. They had 28 patients with retained products, 7 without. 82% of the patients with retained products of conception had flow identified by Doppler imaging. No flow can be seen in either, and they had one case without retained products that still had mild flow. So it seems that endometrial flow, especially when equal or more vascular than the myometrium, does seem to favor retained products of conception. Now occasionally you run into patients who don't have a focal mass, or they don't have thickening, but you just see this complex fluid, has internal echoes, or it's heterogeneous material, and it's hard to tell what's going on. These are 2 different patients, neither of which had retained placenta in the postpartum period. Now this complex fluid or heterogeneous material is a bit problematic because the terminology varies, and we really have no consistent terminology to describe these. Varying significance has been reported. It seems that this complex fluid or heterogeneous material is usually not due to the placenta. Placenta tends to be more homogeneous, hyperechoic. Again, not totally reliable, but can at least suggest that if it's more heterogeneous, it's less likely to be retained placenta. And the other thing you can look for when you see this appearance is either spontaneously or maybe with a little transducer pressure. If it's just complex fluid, you can see some motion of that fluid while you're imaging. Now, what about patients who've already had surgical treatment? What we've talked about so far applies to the patient who has been pregnant, then have bleeding, and the question is, does she have retained products? Sometimes that's already happened, they've gone on to a D&C, and then they're still bleeding, and we have to decide, is there still retained products? Well, in this study, within the first week after a D&C, it almost always looks abnormal. 74 patients, all of which did well. About a fourth of them had a thin endometrium defined in that study as less than 7 millimeters. 50% had a 7 to 19 millimeter endometrial thickness. and about another quarter of the patients had greater than 19 millimeter thickness of the endometrium or heterogeneity. And again, all these patients did well, so we might be particularly concerned about this latter group with more than 19 millimeters or heterogeneous, but maybe even this middle group. So most of these patients, it looked abnormal. They still did well after a D&C. So it looks like even in these patients, or particularly in these patients, you cannot rely on ultrasound alone to decide who needs further intervention. You probably need to follow them up with ultrasound in many cases. Wide overlap in the ultrasound findings of symptomatic and asymptomatic women after surgical intervention. Most features did not discriminate, neither the appearance nor the Doppler findings. Endometrial thickness was a little thicker in symptomatic patients, but still a lot of overlap. And in this study, they concluded that asymptomatic women after termination of pregnancy often have thick, heterogeneous endometrial contents with flow by Doppler imaging, and that does not necessarily equate to retained products of conception. So my approach to the first trimester patient with question of retained products of conception is if you see a gestational sac, then it's easy. You know there's retained products, but that's usually not the easy case. So if you do not see a gestational sac, the ultrasound tends to indicate the amount of material, but it's more difficult to tell what that material is. If you see extremely thin endometrium, it's less likely to retain products, so I think we're better with ultrasound at determining that the uterus is empty. More problematic when there's something in the uterus to tell what it is. It seems at this point that an endometrial mass is probably the best predictor of retained products of conception, but seems to have low sensitivity. This is probably more useful, that is, endometrial mass is probably more useful in the first trimester, less useful in the first 2 weeks postpartum when you can see this more as a normal finding. As far as Doppler findings, the data is still somewhat sparse, reliability unclear, but certainly it seems that there's at least a trend that if endometrial flow is present, retained products of conception are more likely. No flow detected by Doppler favors clot, but could still be retained products of conception. If you don't have a mass, but you're only going by endometrial thickness, I currently use 10 millimeters. 8 might be reasonable also, to say that clinically significant retained products of conception are unlikely. And that's how I tend to report out these cases in these patients, that if it's less than 8 to 10, I currently use 10, but it would be hard to argue which is more reliable. That if it's less than about 10 millimeters, I say clinically significant retained products of conception are unlikely. Doesn't mean that there's not a little bit of retained products, but at least based on some data, it seems that these patients tend to do well with conservative management. If it's more than about 10 millimeters, then I think it's problematic. I would use color power Doppler to push me one way or the other, with flow favoring retained products, lack of flow favoring clot, but again, neither totally reliable. Now, what about the postpartum period? Let's talk a little bit about the normal postpartum uterus, C-section patient, and a few other miscellaneous abnormalities. We've already talked about retained placenta, retained products of conception in the postpartum period. One thing to mention is, how do you scan these patients postpartum? Well, even though most pelvic ultrasound currently involves transvaginal scanning, you generally don't need this, at least in the first 2 weeks postpartum. Transabdominal scanning tends to work quite well in the majority of patients in the roughly first approximate 2 weeks postpartum. The uterus is still large, displaces bowel, it transmits sounds easily, and it's just going to be more comfortable for the patient. After about 4 weeks postpartum, you probably are going to need the transvaginal scanning in many patients. And those intervening 2 to 4 weeks, I think you just have to take it on a case-by-case basis depending on how well you're seeing abdominally and patient comfort issues. The normal postpartum uterus in the first few days can still be soft, can still be easily distorted by the transducer here. Here's the transabdominal scan, sagittal, and you can see we can actually deform the anterior surface of the uterus easily with just transducer pressure. Contractions can still occur. We know uterine contractions, that is of the myometrium, are common during pregnancy, and they can still occur in the early postpartum period. The other thing I've noticed in the early postpartum period, and here's a patient 4 days, is that the inner myometrium can be hyperechoic, more hyperechoic than we're used to. Here's a patient at 8 days. So much, in fact, that sometimes, at least on first look, you may wonder where the endometrium is. Is it just this thin area? Is it all of this? But if it's all of that, that's quite thick, and the same thing here. But this is just the inner myometrium, and I've just noticed that in the early postpartum period, it can be hyperechoic, more so than usual. It may even occasionally give you trouble deciding where the endometrium is located. Later in the postpartum period, the uterus is certainly going to decrease in size. The most rapid decrease in size is the first 1 to 2 weeks. And the size of the uterus is typically back to its non-gravid size by 6 to 8 weeks postpartum with no effect from breastfeeding on that return, size return. Now, the area where ultrasound can often help in the postpartum period is hemorrhage. The definition of postpartum hemorrhage is more than 500 cc's blood loss after a vaginal delivery or more than 1,000 cc's after cesarean. It's usually separated into primary or early postpartum hemorrhage, which is typically defined as hemorrhage in the first 24 hours, and then secondary or late postpartum hemorrhage as that occurring 24 hours to 12 weeks postpartum. The most common causes are these. Uterine atony is certainly the most common cause, particularly of primary postpartum hemorrhage. Retained placenta, or even you can occasionally get placenta accreta postpartum, is certainly a cause also, and often a reason that ultrasound is performed. This is a little more likely in the secondary postpartum hemorrhage, but also can occur with primary. And then the other causes to remember are trauma, that is lacerations to the cervix, vagina, or perineum. Occasionally uterine rupture, though not very common, and then coagulopathies can also be a cause of postpartum hemorrhage. We don't typically need it for hematomas due to lacerations, but you may occasionally see it. Here's a sagittal view of the cervix. Here's a hematoma in the cervix from a cervical laceration, but we don't typically need ultrasound to make that diagnosis. Uterine rupture, historically in the literature, has been difficult to see. We've often depended on secondary findings of intraperitoneal fluid. Occasionally you can actually see a cleft in the myometrium from a uterine rupture. I think we're getting better at seeing that with ultrasound, but you may have trouble visualizing the direct site of the defect in some patients with uterine rupture. We talked about retained placenta in the postpartum period and ultrasound findings. We talked about this earlier with mass, thickness, and Doppler findings, and wanted to mention a couple of other things that you may encounter more frequently in the postpartum patient than in the post-miscarriage patient. One is fluid only. Anechoic fluid like this is not uncommon and does not typically mean retained placenta and will usually resolve on its own. The other thing you may occasionally encounter, it's not very common in my experience, but certainly not rare either, are these little hyperechoic, tiny echogenic foci in the endometrium. This is usually air. It's been shown that air can persist for several weeks postpartum. It can be normal or due to endometritis. These echogenic foci, as long as you do not see them within a mass, are usually not due to retained products. So I typically, when I see these, try to decide, are they just kind of random scattered in the endometrium, or are they within a mass of tissue? If there's no mass, it's probably just air, and it's probably not retained products. Theoretically, if these were very extensive air, it could obscure some retained placenta, but I think that's pretty uncommon. If you see it within a mass, as in this case, here's a mass with these echogenic foci, then it is more concerning. Probably is calcification, and it could be mature placenta with calcification that's retained postpartum, because we know that the placenta does, during pregnancy and the later part of pregnancy, have more calcifications. Or perhaps if it's been retained for a long time, even postpartum, you could get some more dystrophic calcifications. So I get more concerned about hyperechoic foci. If there's an endometrial mass, more likely to indicate retained placenta in those cases. What about serum beta-HCG? Probably can't rely on totally. There was a small number of cases in this study, and you can have pretty low HCG levels. About half the patients had low, very low to no HCG levels, so probably cannot depend on serum HCG to exclude retained placenta postpartum. Now we'll move on to the post-cesarean section patient, talk about some normal findings, and talk about some of the hematomas we can see there. The low transverse incision is by far the most common location of the hysterotomy that's performed. It's a horizontal incision in the lower uterine segment. These have a lower risk of hemorrhage, infection, and later rupture. What do we see? Well, is a patient transabdominal scanning 4 days after a cesarean section, and you see a few little small echogenic foci, a little subtle mass-like area. There's a different patient 2 weeks postpartum. This one is transvaginal. So now the anterior lower uterine segment is here because this is a retroflexed uterus. So we see a few little hyperechoic foci. These are probably the sutures. And this is essentially a normal finding to see a subtle hypoechoic area with echogenic foci. It's usually less than about 2 centimeters. There's no hard and fast size cutoff, but it's usually less than about 2 centimeters as a normal finding in this so-called bladder flap area in the lower uterine segment. If it gets larger and there's no hard and fast number again, it's usually more than about 2, maybe 3 centimeters. If you see a mass-like area there in the region of the C-section scar, and here's an older case, a distinct mass-like area, anterior lower uterine segment. These are typically referred to as bladder flap hematomas. Now, there's still a few patients who have the old classical incision for their hysterotomy. For a cesarean section, it's a vertical or longitudinal incision higher up in the body of the uterus. It's used in some emergency cases. Sometimes there's difficulty performing the lower uterine segment incision. So not frequent, but you may still occasionally see patients after a classical hysterotomy. Now, what do these look like? There's not as much published about these, but here's a patient 6 weeks postpartum, and post-cesarean section with bleeding. Vaginal ultrasound, sagittal view of the uterus. We have one of these kind of mid-position uteruses where the fundus is directly away from the probe, and we see this area of heterogeneity kind of in the anterior myometrium and a little bit here too. And we were concerned at first, is this some retained placenta? But in fact, MR in the same patient, T2 weighted image, we see virtually nothing there. On the spoil gradient echo images, we're seeing susceptibility artifacts, probably related to the sutures from the classical hysterotomy, and there was no evidence of retained placenta on MR or on follow-up imaging in this patient. So this seems to be normal for a patient after classical hysterotomy. Here's another patient, 4 weeks post-cesarean section. Sagittal view of the uterus. We're not getting all the way up to the fundus, but you can see some echogenic foci in the anterior myometrium. And on this video clip, I think again you can see multiple small hyperechoic foci in the anterior myometrium. This was due to the classical hysterotomy, probably due to the sutures used. Another location you can see hematomas besides bladder flap is the so-called subfascial hematoma. They tend to be more anterior, often anterior to the bladder in the prevesical space. So if you're not seeing this area well with your usual vector or curved probe, you might even consider a linear probe looking more superficially to look for these subfascial hematomas. There's another one, a larger subfascial hematoma. So remember, look more anterior, look superficial, and if they're small, you may overlook these and consider using a linear transducer if you're suspicious but not seeing this area well. Now, a few other miscellaneous things, a few that are uncommon causes of bleeding in a postpartum patient. Placental site trophoblastic tumor is probably the least common form of gestational trophoblastic disease. It can follow any type of normal or abnormal pregnancy, though usually it's after a full-term pregnancy. Patients usually have vaginal bleeding, not always, but usually, and it can be anywhere from weeks to years after delivery. It's even been reported up to 14 years after delivery. Patients may or may not have amenorrhea. These tumors are composed of intermediate trophoblasts. So the HCG is usually normal to only mildly elevated, and there's actually another marker, human placental lactogen, that's often increased in this type of trophoblastic tumor. They have variable biologic behavior. They're less chemosensitive than other forms of trophoblastic disease and may require hysterectomy. They have a malignant behavior clinically in about 10 to 15% of patients. So the ultrasound appearance is variable. It can involve the endometrium and or the myometrium. Here's a patient with heterogeneity, cystic looking space in the myometrium on this transverse view. With Doppler imaging, you see pretty abundant low resistance flow in this region, pretty vascular, low resistance. You might even be thinking about an AVM, but in this case, this turned out to be placental site trophoblastic tumor. Another thing to remember is placenta accreta. We often get more concerned about this in During obstetric scans, antepartum or even intrapartum, patients are having bleeding, but occasionally it can actually present in the postpartum period. And here's a patient with this hyperechoic mass, not just an endometrial mass, but actually seems to go out and extend almost to the serosal region of the uterus in this postpartum patient, and this is retained placenta increta. Retained placenta MR may help, but the incremental value over ultrasound, even in the postpartum patient, is not clear. It might be more helpful in the postpartum patient actually, because we could give gadolinium to these patients, whereas we wouldn't typically do that in the obstetric patient who's still pregnant. The potential problems I've encountered are it can still be hard to tell what's thinning of the myometrium from just invasion. And even with myometrial vascularity in that region of thinning, it can still be difficult to tell. Here's a patient, postpartum placenta accreta, T2 weighted image, high signal intensity mass. We thought the myometrium here was just quite thin. Here it is after gadolinium. But hysterectomy was performed in this patient, and she did have placenta accreta. She did have the mild form, placenta accreta vera, but we interpreted this as thin, whereas pathology, it was actually invaded. So another question, low resistance arterial flow in the myometrium of a postpartum or post-abortion patient is abnormal, indicating retained products of conception or an AVM. True or false? Well, false. What we know is that you can occasionally see this as a normal finding. So a little background, because we may be thinking about uterine AVM in such patients. Most uterine AVMs are acquired due to trauma, often from dilatation and curettage. It's not necessarily postpartum, post-miscarriage patient. It could be curettage performed for any reason. They typically present with bleeding, many times massive bleeding that may require transfusion. And it's important to identify these patients, as you may want to consider treating with embolization rather than dilatation and curettage. What do AVMs look like? Here's a patient, retroverted uterus, transvaginal scanning, sagittal view. We see all these little cystic to tubular spaces in the myometrium. And then with color and spectral imaging, we show this focal increased vascularity with low resistance arterial flow that's typical of a uterine AVM. It's important to realize that these uterine AVMs can be overdiagnosed, particularly in the postpartum or post-miscarriage patient. Focal low resistance flow in the myometrium can be seen after term delivery and after spontaneous abortion, and it's thought to be due to what's been termed in some studies subinvolution of the placental bed. Its incidence has been reported to be the highest in the second postpartum week. Now you can also see this focal low resistance flow with retained products of conception or even with a molar pregnancy. What we're recognizing is that many of the so-called AVMs, what sometimes have been diagnosed as AVMs in the postpartum period, actually resolve spontaneously. So it's important not to overdiagnose these, not to rush off to treat them with embolization. So when you're considering this diagnosis of a uterine AVM, if the patient was recently pregnant and stable, don't rush off to treatment right away. You may want to check the serum HCG, look for other evidence of gestational trophoblastic disease, and consider a follow-up ultrasound in these patients because many of these will resolve. And lastly, ovarian vein thrombosis. CT or MR is certainly going to be more reliable in most patients for this diagnosis. Here's a CT scan, the thrombosed right ovarian vein. So we are going to depend more on CT-MR to make this diagnosis in many patients. But the point I'd like to make is that when you do pelvic ultrasound in the postpartum patient, and that often is the first imaging test, whether it's for bleeding or pain, don't just look in the pelvis. If you're even remotely considering this possibility of ovarian vein thrombosis, look a little higher up out of the pelvis than you probably typically would for many patients during the pelvic ultrasound. Look up where the right ovarian vein would typically enter the IVC. Here's a transverse view more through the mid-abdomen, aorta, IVC. Here's this thrombosed ovarian vein. We turn longitudinally on the inferior vena cava, and you can actually see a little bit of the thrombus as it protrudes into the inferior vena cava. So look a little higher up. You're more likely, in my experience, to make the diagnosis if you look here than just in the pelvis in these patients. So to summarize, retained products of conception or placenta, a hyperechoic mass seems to be the best feature. However, it's probably less reliable in the postpartum patient in the first approximate 2 weeks. If you don't have a mass and you only have endometrial thickness to go by to predict retained products, I think based on what's out there at the moment, somewhere 8 to 10 is probably the best cutoff. I currently use 10. However, admit we really don't know the most reliable thickness to discriminate patients who can be treated conservatively. But if it's less than approximately 10, clinically significant retained products of conception seems unlikely. Doppler ultrasound can certainly sway you. Seeing flow favors retained products. Lack of flow favors clot. So it can certainly push you one way or the other, but it doesn't seem that either is totally reliable at this point. For retained placenta, remember that hyperechoic material, complex fluid, can be difficult. Try to distinguish it from a true mass, which would be more focally hyperechoic, but complex fluid or hypoechoic material is probably not predictive of retained placenta. If you see hyperechoic mass, that seems to be more predictive. If you only see echogenic foci in the endometrium, I would try to determine whether it's in a mass. In that case, I'd be more concerned about retained products, or whether it's just scattered diffuse echogenic foci without a distinct mass. In that case, I think it's more or less likely to be retained products. Remember that there are other serious causes of vaginal bleeding besides retained products. They're rare, but you want to at least keep them in the back of your mind. That is AV malformation, postpartum placenta accreta, and placental site trophoblastic tumor. And still be very careful about diagnosing AVMs in the postpartum or post-miscarriage period. Even though subinvolution has been described more in the postpartum patient in the first 2 weeks, I have occasionally seen it in the first trimester pregnancy losses where there's abundant low resistance arterial flow focally in the myometrium, and you follow those patients and it resolves. So be very careful about diagnosing AVM in the postpartum or post-miscarriage patients. It's often subinvolution of the placental bed, and if those patients are stable enough, just follow them, and many times those Doppler findings will resolve. Remember the post-cesarean section patient, know the normal appearance. Beware of the appearance in the or less common cases of the classical or vertical incision in the uterus. Hematomas in these patients is the most common in the bladder flap area, that is the anterior lower uterine segment, but also remember subfascial hematomas